Here. Good morning, Friday friends. There is a lot to cover and some pretty serious stuff to cover. So buckle in. We're
Hey,
going to
Tammy,
start. Yeah.
I see you viewing it in presenter mode.
How's that?
Thank- Yes, perfect.
Um, Sorry about that. My computer has been funny this morning. So here we are. Blow past that 30 seconds if you're on YouTube. As always, we're going to start with the state legislature. So if you're not from Wisconsin, you can, you know, take a break and come back. Um, and then we will move into what Congress is doing. And there's a tremendous amount that we're going to be covering that the federal administration is doing and activity in other states that I think will be important for not only Wisconsin, but everywhere else in the country. So in Wisconsin, the state assembly last Friday ended its session. And what that means is because all bills have to be approved by both the full assembly and the full Senate before they can be sent to the governor to where he can decide whether to sign them into law or veto them. That means any bill that hasn't passed the full assembly is not able to become law anymore. We say in the business, the bill has died if it doesn't make it through a piece of the process that it needs to before the end of a session. So the assembly made some decisions about what to do and what to not do. And a couple of those things are on issues that are important to people with disabilities. We'll talk about those in a minute. What it means now that the assembly has ended their session, the state senate kind of has a list of bills that it can choose to either act on or not. And, the menu of bills that can become law is the set of bills that has already passed the state assembly. So they have to look through what has passed the state assembly and decide whether or not to act on those bills. And any bills that the Senate had that didn't go through the assembly are already dead. And then there are bills the assembly has passed that they can kind of look at and go, well, if we pass this, then it can go to the governor's office, for the last step in the process. The Senate is only planning to meet once in March. They want to end their session too. So this is kind of, I'm hearing March 18th is the date they'd like to be done. And that would mean that anything that has not passed both the Assembly and the Senate would be done for this session. So we're kind of getting down to what is the narrow group of things that still has a chance to become law or not. We're going to start with food share, which has been something that we have been following ever since federal HR 1 passed in July. You may remember that HR 1 made some significant changes to the Supplemental Nutrition Assistance Program, which is known as food share in Wisconsin. And among the many changes, states have been figuring out since that bill passed in July how much money the federal government currently gives they will no longer receive and how much it's going to cost to do all of the extra work and requirements that that bill now requires. So since August, the Department of Health Services has been asking the legislature, kind of calculating, okay, what do we need to do to be able to fully implement the changes that are now required and keep this program running smoothly with as few mistakes as possible. Because now, for states, for the first time, if they have too many errors or mistakes, states get financially penalized and have to pay a lot more money potentially when they're paying nothing now. So the legislature's been hearing about this since August. It did not act In October, the first set of changes from HR1 went into effect. Still no action. In December, another set of changes from HR1 went in. Still no action. And we were at the point where every time, every delay is now potentially resulting in more mistakes and errors because we have not invested in the additional workers and systems that are needed to fully comply with federal law. A large group of hunger advocates have been working pretty constantly since December to try and figure out a path for how to get funding, how to get the legislature to approve the necessary funding. And at the very last moment, late Friday night, on the final day of the assembly session, there was movement. There was an existing bill, AB 180, that was amended to include most of the funding in the positions that the Department of Health Services said it needed to meet the new federal requirements included in HR 1. And it didn't include all of the positions, included 40 instead of 56, and there's kind of a pathway for the department to potentially get up to 56, although not all of those positions are permanent. But it's, considering we were at no part of the ask was being recognized to most of what was asked for is being included in an amended bill, it's a pretty big shift. Now, AB 180 is an existing standalone piece of legislation that also does other things. And it includes a policy change to the existing food share program that directs the Department of Health Services to ask for permission from the federal agency to create rules that restrict what people who use food share can buy with their food share dollars. And specifically, it would it would say that people who have food share couldn't buy certain kinds of products that fall into candy or soft drink categories. There are some states that already have some version of this kind of waiver to restrict what people can buy with SNAP dollars. I think we're about 15 states. And this is a policy that the current federal administration has been pushing states to adopt. You might remember that one of the criteria for the grants, one of the things they were looking at for the rural healthcare transformation grants that were also part of HR 1 was do you have this kind of policy in your state? So there are a number of states that have done some version of this policy, and some of those waivers are more or less restrictive. There are a lot of hunger advocates that are not particularly happy with the policy because it does set up different standards on what people can buy to eat based on how they can pay for those items. It is also a policy that takes time and systems to implement. It will be hard for people to know what they can and can't buy in some cases. And there are lots of systems that need to be built to help retailers know which products are okay or which products are restricted for a subset of consumers that are using this specific type of payment. The bill did also include funding for building some of these systems that would help retailers know which products are on the list of can buy or can't buy. But it also tells us that there are a number of steps, if this bill were to become law, that would need to be taken to implement it. So most of the hunger advocates are looking at this bill as we really need this food share funding, and we need it now. Actually, we needed it several yesterdays ago to avoid mistakes that could mean a lot higher costs for states and to make sure that these food share dollars can continue to support people who need help to buy food and the businesses that sell people food. So all in all, even though there is a policy that will require additional changes and mean something different for people who use food share, the balance of not having the funding needed that could really put the entire program at risk, most advocates are in the position of this is kind of a must-pass situation for this bill. It has passed the Assembly. It has not passed the Senate. This bill will need to pass the Senate in the exact same language it is now in order to become law. And remember, the Senate is meeting in March. So even though this bill has passed the Assembly in February, we still have at least another month before we know whether or not this bill will be approved by the Senate. And that's another month of delay and another month of accruing mistakes and another month of not knowing or being able to fully prepare for the next steps. This is a strategy. We have seen it used before at the federal level and elsewhere, where you attach a policy to another thing that people really need or want in order to get the whole bill moved forward. And it does put people in the position of you may have to accept some things that you aren't a big fan of in order to get the things that you really want or you really need. For those of you who are keeping track, we had the federal change in HR 1 in July. We are still working through how to implement those changes. And the policy in this bill of asking for a waiver will mean that advocates have more things to participate in and watch, because the department will have to figure out what it's asking for. That's the waiver. And usually there's a input time period in there that might be important to participate in. Then the waiver has to get submitted and approved to the federal agency. And then we have the nuts and bolts business of how do we implement that policy change. So you can kind of see that we've had a ripple effect of, federal law changes. Maybe we get the money that we need, depending on what the Senate does. And then because that bill has other changes to the program, there are now other things to watch and participate in that will make a difference for those folks who are using the program. So the action step here is really contact your assembly member and thank them for supporting the funding for food share. It is necessary. It is something that I think some of the legislators, appreciate hearing from constituents when they have done something that they have felt has been very hard for them. And then, of course, the second step is this isn't passed yet. It passed the Assembly. It needs to pass the Senate. So a message to your senator saying, hey, you've got a list of things that you could choose to do or not do. This is one that should be on your to-do list. Another bill that we've been following, and if you've gotten our action alerts, you may have read about it, is a bill that lets hospitals pick decision makers in the event that somebody over 18 becomes medically incapacitated and does not have an existing power of attorney for healthcare or is not under guardianship. Lots of aging, legal, and disability advocates, abuse advocates, pretty much everybody who is worried about patients and what happens to them after they leave the hospital and preserving people's civil rights is on one side of the bill and they oppose it. And then on the other side are the hospitals who would like to get people out of hospital beds faster to somewhere else. So this bill has kind of been rolling around. And I think the important thing for this group to know is that it was amended 4 times, including 2 amendments in the last day of the session, and that those amendments really don't address the core rights and practical problems that advocates are saying will be likely to happen if the bill becomes law. In fact, the sub-amendments actually raise some additional questions, and there are some links to memos that were sent to the legislature by a pretty wide group of folks that will explain the real details of those concerns. We don't think that this legislation will actually resolve the problem that hospitals want to resolve. We spend a lot of time talking about the lack of the caregiver workforce, which, the same people who are trying to help folks in the home and community-based side be independent and remain in the community and remain in their homes. It's the same kind of workers who work in nursing facilities as well and institutions. And there's a shortage of those kinds of workers in both places. So for those of you who are really familiar with how hard it is to hire and find workers to help you in your home, if we were talking to nursing home facilities or rehabilitation facilities or CBRFs, they would also say they are having a hard time finding workers to work in those more institutional settings. And in fact, the Journal of American Medicine just published an actual research report that says the reason why people are getting stuck in hospital beds and can't move from the hospital to a rehab or nursing home facility is because there's a lack of staff. That is certainly the experience of Wisconsin advocates as well. The nursing homes have plenty of beds, but they don't have the people to staff those beds. And you cannot accept somebody who needs care if you do not have the capacity to care for them. So that's one of the major reasons why making changes that would potentially restrict people's civil rights indefinitely, in order to move them may not have any effect if the real reason that people are stuck is because there's no place to go that has the staff to take care of them. And of course, for those of you who are more on the aging advocate side, there is nursing homes are able to choose who they will accept and not accept. And there is, some demonstrated decisions where nursing homes will send somebody to a hospital and then decide not to take them back. So there's kind of multiple layers here of why hospitals may have somebody longer than they want. And we'll go over some of the concerns in a minute. The main point is this bill's now passed the Assembly. So it's on the list of things that the state Senate could do or not do. And I think the patient advocate side would say this is not the right solution. It's got a lot of really big problems that have never been addressed by any of the amendments. And the amendments actually create more questions than answers. Kind of big picture, what are the concerns? And of course, you can read the more detailed memos if you want. This person that the hospital picks, it's called a patient representative in the bill. There are no exclusions for who that could be. So that might be somebody who is in the process of divorce or separation or has a record of abuse for the person. There's no weeding out of potential people. The hospital is picking from a list that would be set in the statute of kind of in a hierarchy of different folks. And that person that gets picked gets really broad authority over the person and their money. In fact, the words guardian of the estate and guardian of the person are in the bill. Like it's giving the equivalent authority to those really significant roles that would be regulated by a court to this person the hospital picks without any court oversight. And that role could potentially continue indefinitely. There's lots of reasons why advocates are concerned about once this occurs, what happens to that person next. And it is a bill that is unlike any other state's next of kin laws. So this is definitely a departure from what all other places have done. So in this case, the action step is if you don't think that this bill is a good idea, your state senator is now in the position to say no and to say, let's just not take it up on the floor. So you don't have to vote no. They don't have to schedule this bill for a vote at all. And if they don't do that, the bill would die with the end of the sessions. We were following two special education bills. As you might remember, the state budget, which was passed also in July, had established a set amount, a percentage of cost that they wanted to reimburse local school districts for special education. And as it turned out, the actual costs of those services and what the legislature set aside were really different. There were two bills that were out there and introduced trying to say, hey, let's provide the money at the level we promised. Those bills did not get a vote from the assembly, and they are dead for the session. They cannot become law. So again, another opportunity to get in touch with your assembly representative and talk about special education. Special education will be a big issue in the next state budget and state legislative cycle. So it's never a wrong move to kind of talk about how those services really impact your local school and district and students with disability. There were a number of other bills that we were following. Some of them are in kind of the place where the Senate could act and then it could move to the governor. That's the first one. Another bill we were following, nope, it's dead at the end of the session. And then there are two bills that already passed both houses that will be done, decided by the governor. The governor can either sign them into law or veto them. Generally, there is a specific date, and I forgot to look it up before I came on, but the governor can request a bill early, which he has not done. Or there's a specific date, probably 4 times a year, where any bills that have passed, both the Senate and the Assembly, are sent to the governor. And then the governor has, I believe, 6 business days under the state constitution to make a decision about either signing it or vetoing it. One other outstanding issue that is not dependent on whether or not the state assembly is still in session is DVR funding. In Wisconsin, we have a fairly powerful committee called the Joint Finance Committee that takes the lead on the state budget, but also is the group of people who are approving state agency requests for more funding, either because they've been told they have to come back to that committee to get money that was set aside released to them for certain things, or perhaps, like in the case of DVR, the amount of money that was appropriated was not enough to meet the needs, and so therefore the cost of the program is different than what the legislature thought it would be when they passed the budget. And that is the case with DVR. The amount of money appropriated in the current budget wasn't enough to serve everybody. And in December, that the department put in a wait list. So joint finance can still take action. They can technically act and approve requests at any time. Most watchers believe that they will meet one more time and that they are less likely and unlikely to meet after the state Senate closes their session, which again, March 18th. So we have about 3 weeks where that's the most likely window of time where joint finance will make a decision on having a meeting and having a vote on approving this particular 1310 request. So the action step here is to engage with those 16 members of joint finance and say, hey, what are you going to hold a vote on this particular request to end the waiting lists and get people, serve people who are already waiting and get us to the place where people who need services can get them in real time. There also are rumors, and there have been for some amount of months, that the governor and the assembly speaker have been talking behind the scenes about a package a legislative package that would reduce revenue, that's tax cuts, in exchange for some short-term spending increases. And there are also rumors that one of the spending increases might include a short-term fix for the current budget shortfall in special education funding. Remember those two bills that failed in the assembly that would have provided the same level of funding for that was appropriate, that was supposed to be coming from the current state budget? Some people are thinking that maybe that ask gets wrapped up into this larger policy discussion that would cut money coming into the state in exchange for this very short-term win for the next year and a half. It's important to remember that the reason we continue to have gaps in special education funding are complex. And these talks do not appear to be about resolving the long-term funding and financial challenges of how are we funding schools in the state, and is what we're doing now the right way to generate revenue to support schools. So I'm planting in your minds here that if there is a special session called that has this package of things, revenue reducers in exchange for some spending fixes, that means that reducing taxes and reducing tax revenue means there will be less money in the next state budget to respond to all of the federal funding cuts that are coming and happening now, as well as meet increasing needs for all programs. And we spend a lot of money on a whole host of things like roads, like education, like corrections, like Medicaid. And a lot of states have done these approaches. When we talk about what is happening in other states, we are frequently talking about states that have already made tax cuts and are now making cuts to programs because of the federal funding cuts. So I'm pointing that out because reducing revenue at this point in time does put increased pressure on the next state budget, which may have a lot of reasons that there will be cuts already necessary. And we've gone through this slide before, but just as a reminder, if the Senate passes AB 180, we will be spending more on SNAP than we have before in this current budget. And then there are all of these shortfalls and also some pretty big unknowns of things that were funded or will have problems because of federal changes, either from the passage of HR 1 or, the impacts on who is in the Affordable Care Act marketplaces or not in those things. We've had a lot of federal funding for grants and other programs kind of cut or stopped, and some other decisions that federal agencies might make that could really impact the next state budget. So it's not only that we know that there are some gaps in the current budget, we are not funding everything at the level that we had promised or that actually meets needs. It's also that we know there will be additional things rolling down the hill that are about to impact states. And later in the presentation, there are about 5 or 6 states that we will talk about where they are already cutting Medicaid and specifically home and community-based services. So I think it's important for us to kind of think about any marketing or messaging on tax cuts as also being reducing revenue that could deepen a problem that we see other states already facing. And many of those states have already reduced their revenue, which is part of why they're in the position they are now. Congress. So you might remember that the Department of Homeland Security did not get its federal 2026 budget approved. It's still not approved, and there's no action to resolve that shutdown. Um, it is not impacting Border Patrol or ICE functioning because those agencies had appropriations from HR1 independently, so they were going to continue operating no matter what happened with the federal budget. This week, Senator Soon, who's the U.S. Senate Majority Leader, said basically gave the green light to the administration that they should do what they could to pay people like in the Coast Guard and the Transportation Safety Association, move money around essentially to pay those workers because they don't expect that the shutdown will be resolved soon. This week was also the President's State of the Union address. It was 2 hours long, and I think the major takeaways were twofold. The president didn't mention healthcare much at all. He spent about less than 5 minutes on it, did not mention Medicaid or research funding cuts or the expiration of ACA subsidies or any specific plan on healthcare policy. And possibly more significantly, he talked about fraud in the context of he thinks there's big fraud in Medicaid and healthcare, and has actually assigned the vice president to be the leader on the war on fraud. The president made the association that immigrant populations were responsible for a lot of the fraud in public benefit programs. There is not evidence that that is the case. But I think the important correlation is the association that there's so much fraud happening that if we just got a handle on that, we would solve so many spending issues that we'd balance our budget. We've talked about fraud over the last year and Medicaid. Fraud is a very specific criminal activity. There are improper payments, which are mistakes, and both fraud and improper payments are a very, very small piece of all of the Medicaid dollars that are going out to pay providers who are providing the care. Remember, Medicaid dollars don't come to the individual people. They are paying healthcare and long-term care and other providers for work or equipment that's already been done or delivered. So we'll talk a little bit more about this in the administrative portion because there's already been some pretty significant developments about what we think this war on fraud will actually mean, especially for home and community-based services. And I think that the last thing to emphasize here is the administration continues to do things, and there continue to be people who say those things are not legal, and we will sue the administration in the court to say those things aren't legal. But Congress continues to not act. They continue to not stop those things or pass legislation to limit, what the actual power is that the administration is claiming to be using. Court cases take time. There have been many instances where the administration has stopped funding, moving to states, etc. And we've followed some of those cases over the last year and a half. These same actions continue to happen, and the process for resolving those in courts takes a long time. But Congress does have a role. They are the reviser of statutes, and they could either create new statutes or amend the new ones to respond to what is happening here. And they're continuing not to do that. So if you are connecting with your member of Congress, that is a question. They have oversight over what is happening, the money that they have appropriated, and asking them how they're using that or why they're not is going to be important. The other two things that Congress is really focused on now, notice I haven't said anything about ACA subsidies. That is done. That is in the rear view. We have not done that, and Congress has moved on to other things. The SAVE Act, which would put in some changes that would impact what you would have to prove in order to be able to vote. It was supposed to be voted, it passed the House a couple weeks ago, and it was supposed to be voted on the Senate this week, which did not happen. Senator Thune has promised to vote before the next recess, which again is at the end of March. Lots of activity is going to happen in March, but only if that ongoing shutdown of DHS has already ended. There are some members of Congress who really, really want this bill to pass, and they want the Senate to get rid of the requirement that 60 members have to agree before any bill can get to the floor. That's called the filibuster, and it has the effect of making sure that a good majority of the Senate, 60 out of 100, think that a bill is worthy enough to be debated by the full Senate. And usually, if you get to 60 votes, there's enough support that the bill would pass. It's also a way that people who don't agree with the bill can say, no, I don't want that bill to go to the floor. And if you don't have 60 members who say that, it's an effective way to block the bill from going to the floor, which means it can't pass, which means it can't become law. There are a number of congressional members who would like to get rid of that rule because they want to have this bill pass and be in place. And if you hear about a talking filibuster, that's their strategy of trying to only have 50 votes to get the bill to the floor. And then assuming you have 50 votes to get to the floor and the vice president votes for the bill, you would know it would pass. Right now, they're unwilling to do that. However, this is not the only voting bill that is being considered by Congress right now. This bill is actually introduced and led by one of Wisconsin's congressional representatives, District 1, I believe, Representative Style. And this bill goes even farther than the SAVE Act. I've kind of hit some of the highlights here. Some of the things this bill would do are things that the Disability Vote Coalition has been very attentive to when there have been state bills that would have restricted, say, voting by mail and other things. So this bill actually goes farther than what the SAVE Act would do. And we think it probably will, again, mean that there are many people who are able to vote now who will have trouble voting or not be able to vote in the future if they don't have these options or have to prove their citizenship. One little thing, and I don't have the language up here, but again, just like when we were talking about Medicaid and HR1, sometimes even the things like, well, if you have, I'm going to use the example of a tribal ID, the bill says, well, a tribal ID counts as your photo ID, but it also says that the tribal ID has to have an expiration date on it, which most of them don't, because if you're a tribal member, you're a tribal member. So it's important, like, we're talking very high level about what are the changes these bills would make. Really reading that text, some of the things that look like, oh, well, this is your pathway to vote, might actually be much more restrictive or not workable based on how the bill is written. So, lots of people who are critical of these actions see both of these bills and also some of the ongoing discussion of executive orders or other strategies that would give the government a greater role or insertion into elections as being really related to control, to wanting the outcome of next fall's election to be as similar to what the current majority is now. And some folks are also talking about even if these things don't pass, throwing enough confusion and allowing enough people to repeat the unfounded claims that there may be voter fraud, especially by immigrants, will perhaps put folks in a position to challenge or object or discount election results that maybe are not in their favor. So there's a lot to say to Congress. This is kind of our standard slide about are you what are you doing to oversee and make sure the money is spent right? But it's also appropriate to talk about voting. It's also appropriate to kind of challenge some of the assumptions about where there is fraud. And I think as we go on, there might be more things to say here about what is Congress choosing to do and choosing not to do. Okay. The administration has done a couple of pretty consequential things in the last couple of weeks that could impact people with disabilities and older adults. There was a big release of Medicaid spending data that was just publicly uploaded. And a lot of this data was basically on what are the things Medicaid spends money on for the last 6 years. Lots of folks are really concerned about this data release because it's done without context, first of all. It is incomplete, which we will talk about in the next couple of slides. And the rhetoric that is being used to talk about this data release is claiming that here's the spending data, and we think that there's fraud and abuse in Medicaid, and now anybody can look for it themselves because we have released this data. And in fact, there have already been a couple of editorials being written saying that, oh, well, now that we know which providers are billing a lot and what services cost a lot, then maybe we can look at patterns. And there's an assumption that high cost spending or the same providers billing a lot might be associated with fraud. That is a real danger because, as we know, people with chronic conditions and disabilities and older adults who need constant care, maybe daily care, it is highly likely that the same providers are going to be billing for those services over a long period of time because they're caring for people that actually have high care needs. What was released and what wasn't is important here. Kaiser Health Foundation analyzed, the millions of lines of data that is now out there in public. There are entire categories of services that are missing, including some of the things that Medicaid spends the most on, hospital care and prescriptions. Between those two things, I believe that's 30%, 7% of what Medicaid spends its money on, and it's not part of this data release. In other words, there was a decision made when releasing the data to not have people look over here, right? So we're not looking at all the data, we're only looking at certain data. And there's a whole bunch of context that also is missing from this big data release that are pretty important when it comes to analyzing Medicaid spending and assessing whether there is any pattern or not. First of all, states are the ones that design their Medicaid programs. This data release doesn't have any information about how restrictive or expansive a state's Medicaid program is. In other words, The state policy is what sets who can get into Medicaid. And there are states with more people in Medicaid than others because they allow more people to use Medicaid. It would be logical to assume in states that have more people in Medicaid that there will be greater use of Medicaid services in those states. States are also the ones who are setting what do they cover. How much services are used in a specific place depends on whether Medicaid covers them. So for example, in Wisconsin, I'll pick a service. Dental services are part of our Medicaid package. That is not true in other states. So if you see that Wisconsin has higher dental service usage than other states, and you're comparing them to states that don't allow that at all in Medicaid, you're not accounting for that with this data release. States are also the ones that set how much each kind of service they will pay. They set the payment rates. And it's the state legislature who is setting specific rates for services. For the veterans of Wisconsin, we have been before the legislature advocating hard for higher pay rates for, say, personal care workers. But there's lots of different services in Medicaid where, say, the chiropractors would like a higher rate for being paid, or certain kinds of specialists that do specialty care. There's a rate for every service that a state decides they're providing, and some states make different decisions. So yes, if you look at a specific service and it costs more in one place than the other, of course it does, because those two places are making different decisions about how much they're going to pay for the same thing. And of course, there are some states where they've made a decision not to pay for certain services that are not part of Medicaid. None of this information accounts for spending associated with certain diagnoses. So there are lots of people who have conditions that have high care or ongoing management costs. All this does is identify high costs that they've chosen to identify. It doesn't say, what that condition is used to treat or anything about the people who are using those services. And there are other factors that can impact spending and costs that are also not accounted for, including whether telehealth or in-person services were used. Why are we spending so much time on that? Because there are watchers who are extremely concerned that this large data release is going to enable people with no particular expertise in Medicaid or how states have oriented their programs or who it serves to essentially decide what is fraud based on where money is spent. And remember, the big category, like 37% of where Medicaid dollars go, isn't included in this data release. Lots of folks are really worried that by saying, hey, you're connecting fraud to services that have a lot of use, that is not a connection that should be made. There are services that are used a lot because they're needed a lot. It's not because somebody is criminally scamming the system. It is because there are people who have high care needs that are ongoing that use a service consistently over time. And of course, you pay more for that. Specifically, home and community-based services are exactly like that. The top spending items, when you do a simple graph, and there has been some of this kind of percolating on social media, top spending items in this data release: personal care, number one, residential rehabilitation, think group homes, and attendant care services. These are all services that are home and community-based services, and they're all relied on by people with disabilities and older adults. if we are framing that things that we spend a lot of money on and we're directing people to only look at certain high spending categories that serve very specific populations of people, if we're saying that that is an indication of fraud, essentially folks are very worried that the core infrastructure of community living is now supposed to be suspect. In addition to the data release, there was a report that was released. You may have heard of the Paragon Institute. Over the past year, some of their members were engaged in writing some of the recommendations for Project 2025, and they have been engaged on the Medicaid discussions that happened as part of HR 1, as well as opposed to extending the Affordable Care Act subsidies. One of their, they have been kind of behind the scenes on healthcare policy, and most of their recommendations are really about how do we spend less, specifically on publicly funded programs. This report, which was just released kind of in tandem with the Medicaid data that was released, specifically identifies home and community-based services and NEMT as vulnerable to fraud because of the way that they're administered. People don't go to a central point to have their home and community-based services. Home and community-based services are by definition designed to serve people where they are in their homes. So this report is characterizing the way that home and community services as work as being suspicious because it's less centralized in terms of how it's administered. The report also specifically identifies applied behavioral analysis services for autism and substance abuse services as, hey, those are suspicious because we're spending a lot more than we used to for a variety of reasons. And because we're spending more than we used to, that, we're making the association that that could be because of fraud. The report has a lot of recommendations in it. Per capita caps for Medicaid, which we talked a lot about last year and was not included as in HR 1, even though the some of the original ideas the House had included that. That is a recommendation from this report. They also are specifically saying, hey, CMS, we think under federal law, you have existing authority that would let you as an agency withhold federal Medicaid funds from states, take Medicaid money back from states, and we'd also like to see you ban Medicaid payments to family caregivers, which many states have in place because there's no one to hire in the paid workforce. So while not a perfect solution, and it has its own set of issues, the reality is that many states are looking at some amount of paying of family caregivers simply because without those caregivers, there would be nobody to provide care. And that those family caregivers are the reason that many people are being kept out of much more expensive Medicaid funded institutions. I just want people to kind of see the rhetoric here because I think it's all going in a very predictable direction. The report also says this. Remember how they were looking at home and community-based services and finding them suspicious because their administration is decentralized? They have a comment about institutional care in this report, and they're framing it as almost a better option because, hey, when you gather everybody in one place, it's easier to administer, and then you can do oversight. This is an old idea of concentrate people into one place, and it's easier for the system. It is demonstrably not better for the people. Orphanages, nursing homes, state centers. There's been a long history of real abuse and problems when you have people out of sight and less eyes on them. But this report is seeing that model as being preferable because it's easier to administer in terms of money. And again, it's specifically saying, hey, home and community-based services are really hard to monitor because people are getting care in all of these unique little sites. Notice the comment on self-direction as being a bad thing in the eye of this report. For lots of us who are working within states that have home and community-based waivers, and in Wisconsin, we have the largest self-directed waiver in the country, this is really targeting the things that are keeping people in their homes. And it's suggesting that institutions might be a better option. The third thing that happened just this week is that $260 million of Medicaid funding that was supposed to be going to Minnesota was halted. Again, remember the data that got dumped, where they were directing people to look for fraud. This report comes out, and there are recommendations about what CMS can do to stop money from going to states. And now this week, there is a stopping of Medicaid money to a specific state. In the State of the Union, the president also mentioned Minnesota and several other states, Maine, California, and I believe Massachusetts, as being, again, potential targets. So this is a pattern that we have seen before in terms of money that's supposed to go to states being withheld. In fact, there's an article that is in the side here about yet another court case about a different pot of federal money that the federal government withheld. But Medicaid money is different. Medicaid money, again, is money coming back to providers who have already provided the care. It is reimbursing providers for work that has already been done. It is not a grant that you're expecting that doesn't come. It is a reimbursement for services that have already happened. And so when there are lots of providers, including small providers, who serve a lot of Medicaid patients that absolutely rely on those payments for work that has been done coming in and on time to be able to stay in business, to be able to pay their workers. Any interruption in Medicaid dollars flowing has immediate impacts, not only on the providers and businesses, but if this becomes an unreliable source of reimbursement and you're a provider, perhaps you make different decisions about how many Medicaid patients you take, what services you offer. And for the populations who need high volumes of care pretty much on a daily basis, if the providers aren't able to serve them because they don't get paid, they're the window between pretty serious impact is pretty short when you stop Medicaid money flowing to states. And it will mean that providers, if this is not resolved and continues, will be in a position where how do you pay your people for doing work that you never get reimbursed for? The AP article here also says that CMS is turning its sights on looking for fraud in Medicare. It will be blocking new Medicaid enrollments for suppliers of durable medical equipment for the next 6 months. So that's an impact for, again, the same populations of people. And again, this reference to, well, maybe we should have just the unknown people look for fraud by soliciting tips and suggestions. That is not the same as investigating fraud where there is some suspicion it's occurred. That is somebody being able to say, hey, I think somebody's getting something that I don't think they should. And having a consequence happen in a way that is not connected to perhaps any investigation. Again, this stoppage of Medicaid money is against an entire state. They are referencing that other states could be next, and it will have an immediate impact. Yes, I'm sure Minnesota will sue about this. But again, lawsuits take a lot of time. And a question for Congress is, what would you do if this happened to the state? If all the CMS has to do is allege that fraud has happened without any particular proof, and they can say that statement and stop or take back Medicaid money that has already gone to states, that is a huge risk for state budgets who rely on these dollars flowing to keep essentially healthcare running for everybody. I mean, Medicaid is one of the core pillars of how we pay for healthcare in this country. And if it becomes less reliable than it is now, that will not work out well for many healthcare providers of all kinds who are trying to figure out, how to get enough payments in to provide the services that they're doing. There is, again, we haven't talked about a bunch about private equity, but there have been a lot of investment organizations that have been buying up providers, home and community-based providers, and autism providers. So again, the person who is receiving the services is probably not the fraudster. And if there is fraud, a lot of the small providers are not they're more likely to make a mistake than they are fraud. But some of these larger groups, there is, in the context of all of these things that are happening, there are definitely folks that are looking at Medicaid, and particularly people who can't get that care anywhere else, which would be people with disabilities and older adults who need long-term care, and trying to figure out how do they maximize profits out of that funding stream and that constant supply of people. So it is something that is in the mix when it comes to, are there folks that are looking at how do I make the greatest investment? Are they making decisions that are driving up Medicaid costs? And if they are, that has a big impact on state Medicaid budgets in the future. And we've talked about specifically ABA autism services being scrutinized by multiple states, potentially because spending has increased so high. Moving to the Affordable Care Act, yes, the subsidies have expired, but that is not the end of changes. In addition to the changes HR 1 is making over this year and the next couple of years, CMS has proposed a rule that would make additional changes. And essentially, this rule would open up more options for insurance that cover less stuff, maybe have lower premiums, but have a lot higher out-of-pocket costs. And there's some changes in there that would allow insurers to cover less, make it harder for people to enroll, and reduce consumer protections. Overall, these lower cost plans put people at much more financial risk for medical debt if they need to use those plans. And according to the administration's own estimates, just the changes in these rules could cause up to 2 million people to drop coverage next year. So when you think about who was covered under the Affordable Care Act last year, it's almost 25 million people. We have yet to see what the first round of changes in HR 1 is going to do to the markets. We know there are less people that are in the marketplace from last year already. And by April, it'll be clearer because people will have to decide if they're going to continue their payments. So we're going to lose a bunch of people this year. And this is a rule that will continue that pattern. And the more people come out of the market and the more people who buy these lower cost plans that don't cover as much, the more unstable that risk pool becomes, which is a real big problem for folks who have to use those plans when you have fewer, healthier people that are helping spread out the costs. The education department has given away some more of its responsibilities to two different agencies. They have not done anything with special education. Partially that is because um, members of Congress, including Republican members, have questioned that. But the will to move those programs is still there. So this is kind of a placeholder of the work to kind of find different homes and make the Department of Education smaller and eventually with the goal of eliminating it continues, but it hasn't quite figured out what to do with special education services, the remaining stuff that it has. We continue to have coverage of adding a citizenship question to the 2030 census. Um, and that's important because adding that question probably will lower the participation and the count accuracy for probably not only immigrant populations, but other least responsive populations. And again, the census matters because the census is, trying to give account. You need to count every person that is in a geographical space. That's how we determine how many seats in Congress that place has. It's also how we determine federal formula grants. So having an accurate census is really important. This is another sign that some old ideas are coming back again in a way that may mean there are places who have a lot of people in them that don't end up being counted and reflected in that sentence. There was reporting this week that Social Security workers have been told to share information about in-person appointments with ICE. Lots of people with disabilities or folks that need an interpreter or anybody who needs to change their direct deposit information. Those are reasons why you would attend Social Security in person. And now Social Security is apparently reporting that information to other places. For some mixed status families, there may be citizens in the household who are entitled to Social Security, but they may have to accompany those folks to an in-person appointment. So this is a kind of new revelation that is happening, but worth noting that, again, there's a whole bunch of reporting and data stuff that folks never used to think about that is now being given to other places for unknown purposes. And kind of following up on, again, on a data question, the Department of Homeland Security has kind of revamped a tool with the idea that even though the rate of non-citizen voting in elections is like almost zero, like it's really not verifiably a thing that happens a lot, they have built a whole new tool that they are encouraging states to feed their voter rolls through, that's supposed to be able to help states identify non-citizens on those voter rolls. And it looks like it's pretty inaccurate. If you read the whole article, there are lots of very earnest, county clerks and voting clerks who are saying, hey, we're getting results, and then we're tracking down those results and finding out that this tool is identifying citizens in a good portion of the time. And specifically, there are a couple kinds of U.S. citizens that it seems not to pick up. It's, I think, another reminder that even though there's lots of data that's being released and now shared, it does not mean that that data or interpretation of it is correct. And moving on to some of the activity in other states, again, keep thinking about that data release that's really focusing energy onto scrutinizing home and community-based services, think about, you know, where that home and community-based services being looked at and potentially being associated or suspected of fraud just because there's high usage. Think about, the restriction of Medicaid funds to one state. And now let's look at what's happening in a variety of states already as they respond really to the coming Medicaid cuts. Lots of states are now starting to think about or having to do repairs to their current state budget, or they're thinking about their next state budget. Missouri, there's a proposal that would, again, mean that family members who are currently being paid, and again, payment rates for the workers who are helping home and community-based services, helping people stay in their homes, that is a target for cuts. This proposal is likely to lead to a wait list for people who are just applying to these waivers by late summer or fall. So again, states only have a couple of different ways that they can cut Medicaid, and they're looking at home and community-based services first because that is where a lot of the Medicaid money is spent. Those are the services that are serving people with high care needs who have them over a long period of time, and those services are technically optional under federal Medicaid law. So there's a reason states are looking in some ways here first, because if you have to make cuts, this is the biggest pot of money first. And states can reduce rates, which is part of this proposal. They can decide to change their policies on who gets paid, part of this proposal. They can establish wait lists, and they can also change what services are offered. And all of this particular proposal would lead to 3 out of those 4 outcomes. Idaho. Idaho is the first state that has proposed to completely eliminate home and community-based services. This is an 18-minute video. It is worth watching if you have time, and it is interviewing 4 people from Idaho about what it would mean if home and community-based services were gone or reduced. And the 4 people who were interviewed, there was one mom who had a young set of twins who have Down syndrome. There was an adult with a disability who, an intellectual developmental disability, uses a wheelchair and a communication device, who's living independently. So somebody who has relied on home and community-based services for their lifetime. There was a person who acquired a disability due to an accident and now is in home and community-based services, relies on that for daily supports, and an elderly parent who is saying, hey, I am now not in the condition and not of the age where I can take care of my daughter who is living independently and relies on daily support and care and services to do that. So I say that because any one of those people, you could pluck them out of Idaho and drop in any state in the nation, and the stories would be the same. Like I listen to it, I'm like, yep, I know people in Wisconsin who have those same stories. And they were talking about, hey, we've already had rate cuts that have happened, but here's these next proposals go much farther. And what it would mean is that a lot of us would not survive. So if you're looking for a refresher on a way to talk about impact and real life and what it means, these folks they're doing it. They're doing what we did last year to try and talk about this policy change and what it would mean to people like them and others that aren't being interviewed. Moving to Colorado. Colorado we talked 2 weeks ago about a proposal that was specifically, again, targeting and capping the amount that family caregivers could be paid for a set of people with intellectual and developmental disabilities who have intense care needs, 24/7 care needs. There's a that proposal was kind of not moved forward, largely due to advocates' work. But there's a second proposal that would again change what is allowable under some current services that are offered. So they are looking at, again, capping the number of hours that caregivers can be paid to do certain things and kind of saying, well, some of the things that we're paying for now we shouldn't be paying for. Um, and that's going to save $10 million. And they are also proposing capping hours allowed for another set of services that's going to save $2.6 million. Again, these cuts are disproportionately hitting parents who are providing a lot of care for their own relatives. And what they're saying is, you're shaving off these hours to save a little bit of money, but the result is going to be you're going to be spending more in your Medicaid budget elsewhere. And I want to highlight this last bullet here because one of the agency folks is quoted as saying, hey, you're not using the benefit correctly. Snarky Tammy comes out now and says, well, if they're not using the benefit correctly, there is a state agency that oversees Medicaid that makes the rules for how it can be spent and has oversight of how money is spent. So they could have stepped in at any time if they thought people weren't using it appropriately and said not to pay it. Moving on, the second part I think is more impactful. Oh, well, it's not intended to pay for duties that are typical parental responsibility. This is kind of a flag for me because we have this is an old idea that parents are expected to do a certain set of things for free, whatever the cost to them, because they are parents. That is an idea that is essentially shifting all of the responsibility onto unpaid family caregivers and saying, we expect you to be unpaid because we do not see that the work you are doing is work that you shouldn't, that is above and beyond what a typical parent would do. And I think that when you look at the low pay for paid caregivers and kind of the value that we have placed on caregiving as a profession, this is another piece of it that falls into it, where we've kind of built our long-term care systems on the back of unpaid caregivers. And then we expect those people to do more and more and do not realize that the care and the people they're caring for are exceptional. That the work that these folks are doing is really professional grade work. That if it didn't happen has huge consequences. So I think whenever I see that, I flag it and go, wait a minute. This is a statement about not valuing what those parents or unpaid caregivers are doing and simply saying, well, they should be doing it anyway, regardless, they don't need any help. And it doesn't recognize what their increased role of caregiving is. And it doesn't recognize that there's no one else to do it because we have not built a paid caregiver workforce that can step in and fill in. Parents are working because there's no one else to hire. Washington State is the latest in the states that is now proposing Medicaid cuts. They're doing it a slightly different way. Remember, states have a few options. They can decide who does or doesn't get into Medicaid. That's what they're doing here. They can decide what rates they provide providers. They can decide what services are or aren't offered, and they can decide to make people who are eligible wait for services. This is a different approach, and it's specifically focused on people with intellectual and developmental disabilities. And again, it's preventing that group of folks from getting into a home and community-based waiver. Much like family care in our state, in Washington State, you have a financial eligibility piece, but you also do a functional screen, meaning you take kind of an assessment that shows how much and what kind of care you need. And if you don't have a high enough need, then you don't go into the program. States can change their functional screen so that you have to have much more care needs to be able to get into the program. And that's what's happening here. So they're not changing what services are offered, but they are changing what you need to, how disabled you have to be in order to be able to get into the program. That means there are some people who can get into the waiver now who won't be able to get into the waiver anymore. And the estimate is about 5,000 people in the state would lose access to services. These changes are creating savings again by reducing the number of people using services. And we talked a lot about this when HR 1 was getting proposed, is that the way that those changes save money is by people losing access to care. And this is a very tangible example for people with intellectual and developmental disabilities. We're removing the line of what it takes to get in. And if you can't cross that line, you are not using services, and that's a cost savings for the state. Maryland is another state that is proposing, has a budget problem, and is part of what they're doing to solve their budget problem is making cuts, about 600 million in cuts. This governor is specifically saying a lot of these cuts are necessary specifically because of some of the activities in HR 1. But again, you have 600 million in cuts that are part of this package. The biggest cuts are proposed to the Developmental Disabilities Administration. 150 million out of 600 million are coming from that particular agency that, again, serves a very specific group of people who are higher cost. They're also doing some things that look like they're freezing rates where they are. And, I'm not an expert in Maryland structure to know if those rate increases for employees within those departments are going to impact folks that are working in institutions and other things. But again, the approach here is important. We have a budget hole. Where are we going first? To the places that we see are spending the most money, which happen to be serving the same kind of people who have the highest needs. The Medicaid cuts, of course, are also going to mean that we're kind of getting hit from two sides. Fewer care workers are going to be coming into these systems just when we need them most. So this is a larger article that probably says things that you already know. When you have less money for Medicaid, the agencies that are employing the workers and nursing assistants might actually get pay cuts to workers. That is a result that could happen. It's the exact opposite thing that most advocates and even provider organizations have been saying. They've been saying we need more pay and better benefits for these workers in order to meet the need that we have and to keep these workers. But we pay for a lot of these folks through Medicaid. And so when Medicaid's reduced, and the rates that go to providers either stay the same or reduced, ultimately that could mean those critical workers are paid even less than they are now, as opposed to more. So this, the person who's quoted in this article is saying, hey, we have a lot more people who are going to need care. It looks like the workforce that's providing that care, which was already too low, is going to be lower. And that's going to have a long-standing impact over the next 4 years. In fact, it will have an impact perhaps for the next several decades. In Georgia, kind of thinking about some of these pieces in a larger context, 15 years ago, Georgia was told by the U.S. Department of Justice, you're not doing a good enough job. You're putting people in institutions just because they have a disability and because you aren't providing home and community-based services as an alternative. And Georgia said, you're right, we agree, and we will do better. But 15 years later, people with developmental disabilities still can't find community placements. And what's happening is they're cycling out of much more expensive institutions, specifically hospitals and nursing homes. There have already been a lot of home and community-based providers that have gone out of business. So that has created a shortage of at least the group home model for lots of people with developmental disabilities. And note that low Medicaid reimbursement rates are one of the biggest factors in whether or not those providers have chosen to stay in business or not. This is the current context, right? This is what is happening right now, even after a decree from a court that says you've got to do better and you've got to invest in home and community-based services. And they still have an immense shortage and providers who are saying, your Medicaid rates that you're approving as a state legislature are too low for me to be able to do this work. And federal Medicaid cuts are coming. You know, some of the decisions that other states are already trying to make in states where there's already a real struggle, where there are already big waiting lists or large groups of people who are unserved, and their system is already shaky. This is kind of a big spiral that is going to hit a lot of states, and make existing problems that are pretty significant a lot worse. And finally, a last couple of slides. Again, SNAP, the Supplemental Nutrition Program, Food Share in Wisconsin, HR 1 made a number of changes that impact states. One of those changes is that if states have too many mistakes or errors, they will, for the first time, have to pay a big penalty. They will have to pay a portion of what they would get from the federal government for food share. And it can be several $100 million, depending on how many people are in food share. So states are trying all sorts of ways to, how do we keep that error rate low or get it lower? Now, the HR 1 also changed the threshold for errors, so it's now easier to make mistakes. They've also increased the workload. There are many more people who have to comply with work requirements, and there's a lot more work that's required. And some of these states don't have very good systems and don't have the necessary people. When we talked at the top of the hour about the money that Wisconsin needs, in Wisconsin, we actually do have people and we do have a system that's in pretty good shape. We just need more of that to make the changes to keep ourselves in the position. And we were one of the states that has the lowest error rates in the country. But a lot of states aren't in that position. So they're trying to figure out, how do we reduce the error rate to avoid getting financially penalized when they don't have people and systems that are particularly well suited to doing that and would need a lot of investment. Now, errors are not the same as fraud. Errors are mistakes by people who get SNAP or even the state agencies. Fraud is intentional theft. So those two things are different. But again, they're getting lumped together, talking about it, because essentially any kind of mistake, innocent or not, is going to count against you and perhaps put the state in a place of financial penalty. There are some people who are committing fraud in SNAP. There are a few people who are trying to get SNAP benefits and they're not eligible for them. That does occur. But the bigger source of fraud is organized electronic SNAP theft by thieves who are taking control of the electronic benefit transfer accounts, and maybe like when you swipe your card, somehow the card swipe is skimming off some of the money, other kinds of attacks and scams. That is probably where most of the fraud is occurring. And the states aren't looking at those thieves, what they're turning their focus to is how do we focus on the participants? So they don't have the staff, they have outdated technology, and they have all these changes that need to happen, and they want to reduce error rates. But the policies they're putting in place to reduce error rates are all things that the recipients of SNAP are going to have to do. Checking SNAP recipients' eligibility more frequently, with the hope that you find people who are on SNAP that shouldn't be and you can kick them off, or that people don't do what they need to stay on and they go off. So that's a policy that is designed to keep people out of the program. But it also has a big cost to the state because you have to do, if you're checking more often, you have to do all of that work multiple times. And there's some evidence that just because you increase that workload, you might not actually lower your error rate. It's especially true if the states don't do extra paperwork. So where the policy is focusing is exactly where the fraud is most likely not to be occurring. And I think these are, part of the larger pattern that we are kind of starting to see and is coming into more focus, across programs is where we hear the word fraud and then we're looking in places that it may not be, but who gets impacted are the same people again. The people who rely most on food share, most on home and community-based services, who have the highest degree of care needs, and may or may not have people who can help them navigate. I'm going to end. I'm sorry that was long because we had 2 weeks of stuff to cover.
All good. There was just a comment about, the care that families do, and I kind of answered, just thinking, it was just more of a comment, thinking about futures planning and, that's not, being brought into account to think about, well, what happens when those families aren't there? And then the other one was, what do they do in other countries? What are the models in Europe for taking care of individuals with disabilities? And then I see that Kathy asked a question about the IRIS FEA, which for those who don't know, DHS is in the process of looking for a new fiscal agent for IRIS. And they're still in that process. And some people who applied to be that fiscal agent have appealed, so there hasn't been a final decision yet on the FEA.
My understanding, just to add to what Sally is saying, is that state procurement law, whole set of nerdy law that most people don't know, it's really detailed, governs what you have to do to set out bids for contracts for state agencies. And it's a whole process unto itself that governs all sorts of different things, not only a contract for an FEA, for example. Part of that process is that the people who applied and didn't get the bid can contest the award and kind of tie out, stop that process. I believe that's what's happened. So there was a procurement process, there was an FEA selected, and there are other people who applied for that contract. Yes, that have now said, we don't think that should have happened, and that's kind of where we are.
Yeah. And I would say tune into the next IRIS advisory because there might be a update there. And then the thing about Europe, are there other models around the world that
I'll answer this in 2 parts. Generally, the United States is actually looked at as a leader for disability rights. Many other countries and places don't have equivalent things to, say, the Americans with Disabilities Act or IDEA or some of the other structures that we kind of talk about routinely, that that really are intended to try and make sure that people with disabilities have equal access and rights to the same things we expect of able-bodied people. So that's kind of one piece. We're looked at as a leader. In terms of healthcare, the United States is really not comparable to a lot of other countries, and we've kind of talked about this when with some of the vaccine changes, like there's been a citation of, well, we looked at Denmark and how they do it. A lot of other countries, especially in Europe, have some form of universal health care, where there's kind of a set price, and a lot of times people pay higher taxes, but their health care is free. They don't pay for it. I won't say there's no problems there, but there's also countries that have much smaller geographies and much different smaller populations and population needs. So it's really hard to compare between countries,
Mm-hmm.
because of those two things being different.
Yeah.
That doesn't mean that like we could sit down and come up with a whole different way of doing things
Right.
here that would be better. I mean, Sally's heard me rage about this, but like I think there was a mistake made when Medicaid was put in place, that there was an assumption that people with disabilities, the only place that they could get care was, we don't subsidize long-term care in private insurance plans. There's no expectation for that. Like Medicaid has become the only payer for that, and you have to be poor to get it. And so it's like there's a mismatch of, there's always been a population with needs. There's always been people who do or don't know have family who's able to fully care for those needs. And you know, there are lots of people who have those needs who would like to not be poor. Like we could think about a whole scheme that would be very different than what we have now. And I just
Sure.
don't see that there's another place that has kind of done that work, either on disability stuff.
All right. I will pass the other question to Tammy, and maybe she can answer
The
it in
other,
the interpreters have other places they need to be. So we
okay.
will wrap it up for today.
Okay, we will have an action, or an action alert, sorry,
I
an
may have
after
said that
message
too.
out this afternoon. Thank you.